Hello, good morning to you all. And as I have committed that I will be doing for the classes, for the online classes for the PGTs of radiology, followed by emergency medicine, and for the postdoctoral in hematology and medical oncology. Now, so today I will be discussing exclusively for the PGTs of radiology. And today I will not be discussing in a random way. Rather, I will be discussing in a question format which came at least quite few years ago in all the universities in some way or other. And radio physics already I have discussed already in my previous video. You can go and watch there. Now today I will be discussing about systemic in head and neck imaging. So I am starting with the question. So the question goes like this: pre-cath workup with the procedure of in DSA cerebral arteries, and write down the name of the intracerebral arteries with a schematic diagram. So there will be you have to draw a diagram of intracerebral arteries with pre-cath workup in the DSA intracerebral arteries. So first we have to know that what is DSA and why it is done, what are the contraindication, what are the procedural workup and procedure, etc. before you answer the question, because this comes as a long answer, because in the previously in RGUHS also, and because I am concerned with the two universities, RGUHS also it came around 2023, and in WBUHS it came around 2021, same type question. So firstly we should go the advancement of the diagnostic imaging, as we already know had greatly contributed to the recent improvement in the X-ray technology. And DSA, which is known as the digital subtraction angiography, is a radiological angiographic procedure to evaluate the blood search using fluoroscopic technique, producing the red time and the continuous images. So this is very important. You should know firstly introductory part, that what is DSA and what are we going to discuss and what are we going to write, because all these questions are very important, and on what principle the DSA works. So the principal initial images from the angiographic sequence are acquired and stored, and subsequent angiographic images are obtained, and the digitally subtract are the initial images for the subsequent angiographic image, and DSA image is equal to subsequent angiographic image and initial pre-contrast image also. And DSA image shows the contrast filled blood vessels without interference from the background. It helps to visualize the blood vessels in a dense soft tissue environment, and it removes the bones and soft tissue from the lungs. So this is one of the very, very important point to be noted, that it removes all the dense soft tissue environment, so that you can have a clear cut imaging of the particularly bones and soft tissues are removed, so you can see all the contrast filled blood vessels without interference from the background. So this is one of the most advantages. And firstly we are starting with the indications. Now what are the solid indications? The solid indications for the pre-cath workup and procedural diagnostic DSA are to diagnose the vascular malformation, that is AV malformations, and to diagnose the AV fistula. It can be acquired also, or it can be acquired, it can be secondary also for the CKD patients. And to diagnose the vasculitis or oculomotor disease, non-traumatic subarachnoid hemorrhage, aneurysm, and to exaggerate the vascularity of the tumor. If you want to know the vascularity of a particular tumor, then the DSA is a very procedural choice, and it is a very investigation of choice also, we can say. And for therapeutic also, endovascular management of the aneurysm, whereas embolization, angioplasty, and thrombolytic thrombolectomy. So these are some of the diagnostic indication and therapeutic indication. Now we are coming to the contraindication, particularly as in the case of DSA, there is no absolute contraindication, and in contraction indicating the underlying condition should be corrected or preventive measures should be taken. Relative contraction is the like renal dysfunction, abnormal coagulation profile, non-cooperative patient or congestive heart failure, respiratory failure patient, they can be also challenging. Pregnancy and history of the previous contrast reaction. If there is any contrast reaction or something like that, that we all know actually. So, but this all the but in the long answer question you have to write this as a in the prompt way. Now the procedural workup is the first you have to know the history. Brief clinical history should be taken before performing the DSA, and present complaint, significant past history and surgical history, and clinical medication and targeted clinical examination must be performed. And then we are coming to the explain the procedure of the patient, and we have to take the information consent also as a part of the medical legal procedure. And the laboratory reports should delineate the PT, INR, platelet count, hemoglobin, EGFR results should be checked, and NPM before the procedure for solid non-clear fluids, NPM for 36 to 8 hours for the clear fluids, NPM 2 to 4 hours, and maintain inadequate hydration of the patient. And guidelines for specific condition is like patient on heparin, like the patient on heparin should be stopped 2 hours before the procedure, because heparin infusion can be restart 2 to 4 hours after the manual procedure has been of the catheter, manual remove catheter sheath. And if the patient is on molecular weight heparin, he or she should hold the dose before the procedure, because many patients are there, they are comorbid with any other disease like liver disease or kidney disease, whatever, or any hematological disease. So for that, for 2 to 4 hours should be stopped, and then after that it should be started promptly. Now patient on warfarin discontinue 3 to 5 days before the procedure. The INR persisted elevated, vitamin K 3 to if now here if INR is elevated, then we should promptly before the procedure takes place, we should administer vitamin K 2 to 10 mg, may be administered 24 to 48 hours intravenously, 12 to 24 hours before the procedure. For non-urgent case. For urgent case, FFE or free floating plasma may be alternate, and the INR should be 1.5 or less. The target INR should be 1.5 or less, because actually no high INR or less INR should be accepted, because this is normal INR of a normal patient. Now the procedure, what is the procedure? The procedure is very important. The procedure is patient must be in a comfortable position, and antiseptic dressing and draping should be there. Then the procedure is performed with a continuous physiological monitoring. The basic physiological monitoring is there, must be there, and local anesthesia should be indicated before the procedure. Now first we have to do the femoral artery puncture. Localization of the femoral artery puncture should be performed by palpitation, URG or fluoroscopic guidance. And fluoroscopic guidance indication of the puncture site, it prevents high and low arterial entry, and the arterial entry site should be over the middle and the femoral head, and its skin should be skin and entry should be over the lower half of the forehead. So this is also very important. And puncture the artery by using the Sildia technique, and the advancement of the guide wire preferred, because we actually prefer the Sildia technique, but if any advancement guide wire is required, we can use that. And firstly we have to catheterize. After the advancement of the guide wire into the aorta, the several dilators are introduced over the guide wire, and subsequently exchange of the desired catheter is performed over the wire, and frequent flushing with hepatinized saline should be performed to prevent further thrombus formation. So this is also very important. During the procedure also we have to continuously wash by heparin, so that the thrombus formation would not be there. So, and image contrast and designated image performed. Now intracranial, about the procedure, intracranial vasculature. The intracranial arterial system is divided into two parts. Firstly anterior circulation, then is a posterior circulation. In anterior circulation, it consists of anterior carotid arteries, internal carotid arteries on the both sides of the branches, and it is terminal. It has terminal branch, the locus of cerebellar artery and the middle cerebral artery. So this is also, and one is the posterior circulation. It consists of a bilateral vertebral arteries and their branches, and the basilar artery and the branches and terminal branches of the basilar artery, and so bilateral posterior cerebral arteries. Now, anterior circulation, internal carotid artery and branches. The internal carotid artery, the branch of the continuation of the carotid artery originating from the neck. It is divided into two parts. The cerebral segment, C1 segment, extracranial part of the cerebral artery it is, and no named branches is persist to cervical segment. Then petrosal segment, C2 segment are like that. Lacerum segment, C3 segment, then C4 segment, and followed by the C5 segment. So this is also very important, and you should locate each and every segment very efficiently to do this procedure. And then there is ophthalmic C6 segment, and the C7 segment is the communication segment. Now, when we are coming to the anterior cerebral artery, anterior cerebral artery is one of the internal terminal branches of the internal carotid artery, and at A1 segment it extends from the original to the posterior communicating ACOM artery, and it has two groups of branches, two groups of the branches of the segment artery, and the intracerebral intracholesterate branches, and then comes the A2 branches, and then comes the A3 branches. So these are the various things. Then you have to come to the middle cerebral artery. The terminal branch of the ICA has four segments, like the herniated horizontal M1 segment, not herniated, horizontal M1 segment extend from the origin of the bifurcation of the MCA and branches to anterior temporal artery and the lateral lenticulostrate group of arteries. Now just we are coming to the inocular M2 sequence, then operacular M3 sequence, then cortical 4 sequence, then posterior circulation. Now in the vertebral arteries also we have the extrosseous profundus precranial V1 segment, then formated V2 segment, then featured extracranial V3 segment, and then we are coming to the basilar artery, the posterior cerebral artery, as we all know, the pre-containing P2 segment and quadrennial P3 segment and quadrennial P4 segment. Now in this way, calorial P4 segment, it is also less than the divides into the media into the tract and the medial terminal branches and the caline artery. So the medial occipital artery, parieto-occipital artery and posterior splenic artery, the lateral occipital artery organizes from the lateral terminal trunk. So in this way the DSA procedure is done, and the colonnade magnetic resource imaging and the magnetic intensity projection images showing the various numbered segment of the internal carotid artery. If you do then MIP or MR by doing the DSA, you will easily see the picture. And just I have briefed about the middle cerebral artery and the posterior cerebral arteries, and this you have to write also, because in the case of the question, if the question is given like pre-cath workup, what are the pre-cath workup and procedures of the DSA, internal cerebral diagram, write the names of intercerebral arteries with schematic diagram. So they are asking about not the DSA as such, they are asking the total definition of the intracerebral arteries with a schematic diagram. So this way you have to move ahead. Now Now, this is also one of the important question which has came quite a long time from these two universities only. In DNV it came, and in RGUHS also it came. Radiological anatomy of the central skull base and imaging in CSF area. This is very important, and they are asking about the radiological anatomy and central base imaging of the CSF area. Now, before that, you have to understand the skull base is a complete anatomical structural flowing floor of the cranial cavity and separates the brain parenchyma with the suprahyoid neck and the facial structures. Now, numerous important structures, especially the neovascular structure, pass through the skull base foramina. The skull base area is inaccessible for direct clinical examination, whereas the imaging techniques resulted in the improvement of the surgical technique and the functional outcomes. Now, CT and MRI actually can be accurately visualize the skull base region and evaluate the extent of the relationship with the adjacent vital structure, and CT and MRI complete each other, evaluating the skull base lesion. If there is a skull base lesion, CT MRI is the best. Now, anatomy, you should know the skull base is formed by the 5 branches, as we all know: frontal, ethmoid, sphenoid, occipital and paired. And the endocranial part of the skull is divided into the anterior cranial fossa, medial and posterior. So if you are coming to the anterior cranial fossa, anterior cranial base, it is separates the anterior cranial fossa with the structure with the orbits and paranasal sinus, and boundaries are anteriorly posterior wall of the splenic sinus, and posteriorly lesser wing of the sphenoid base, and floor of the cavity, and the ethmoid and the initial plate of the bone of the laterally, and here the moves to the transverse from the olfactory nerves to the olfactory bulb. Fracture of the cerebral plate commonly result in the lateral where the anterior ethmoid enters in the cerebral bone is the most common cause of the CSF area. So that we all know. And there is a central skull base. The central skull base is the floor of the medial cranial fossa, and the authors denote that the central skull base are as a poorly defined organ concerned with the pituitary fossa and surrounding structures. Now, here the central base structure I will be discussing in brief, that what are the central base structure, and then you have to read from your textbook. Like in central base structure, we have anteriorly the tuberculous line, anterior clinoid process, etc. are there. Posteriorly, superior bundle of the petrosus superior bone and the dorsal flexion, dorsal cella. Then in the medial cell components of the body, sphenoid bone, and offline parasagittal compartment for the middle cranial fossa, etc. And then foramen lacerum is there. And important landmarks of the anatomical landmarks is sella turnica, cavernous sinus, optical canal, foramen rotundum, spinosum, duodenal canal, and pterygopalatine fossa. Boundaries are in the posteriorly it has parietal plates, medially it has like palatine bones, etc. So I am not going in that details, but you have to write this. So because if this question comes, radiological anatomy of the central base with imaging in CSF area. So first you have to write the radiological anatomy of the central base of the skull, and posterior skull base also you have to write. Now CSF rhinorrhea. Now we are coming to the CSF rhinorrhea. Now CSF rhinorrhea is a clinical condition characterized by the extracranial leakage of the CSF into the adjacent paranasal sinus through osteodural defect in the skull base. So this is the main definition of the CSF rhinorrhea. And osteodural defect of the skull base refers to the abnormal communication between the subarachnoid hemorrhage, subarachnoid space, and adjacent paranasal sinus. It increases the risk of spread of the infection from the paranasal sinus to the meningitis. So this should be stopped, and so there is perfect CSF rhinorrhea imaging that we should be readily prompt for, and we should know everything. And what are the causes? Causes are various causes. Are the first important, most frequent causes are traumatic, then heterogenic or congenital malformation or spontaneous. Now, in the relevant anatomy, anterior skull base sequence in the anterior cranial fossa structure with the orbits and paranasal sinus. Now, Now, as far as concerned the imaging, the HRCT of the PN is performed imaging modality with the individual with a CSF leak, and it provides extra excellent delineation of the bony anatomy and helps to identify the bone defect. Advantage: provide excellent delineation of the anatomy and helps to identify the bone defect even in the present of without any active leak. And disadvantage is that no able to detect the concomitant dural effect and not able to differentiate the neural secretion of the CSF collection within the paranasal sinus. Now, for that disadvantage, we come to MRC, that is magnetic resonance cystoscopy, and sequence used is T2 weighted sequence, which will suppress the background signal using the MR chromatography cystoscopy, and it is considered as a positive finding within the identify the CSF neck and communicating with the subcarinal spaces and intracranial paranasal sinus with subsequent hemorrhage with or without herniation of the meninges and cerebral parenchyma. So the disadvantage is not able to provide the clear bony mass, and control is not able to differentiate the mucus secretion from the CSF collection within the paranasal sinus bus. But it has advantages over the excellent tissue resolution, identifies the meningocele from encephalocele and adjacent gliotic brain parenchyma, and so this is the thing. And then we are coming to the CT cystoscopy, because CT cystoscopy is also very much important in the head and neck imaging. Procedure: the bilateral injection of ionic compound in contrast agent about 8 to 10 ml. Keep the patient prone in the Tendelbach position. Patient filled with the foot elevation. About 5 minutes it takes intracranial migration to contrast and optimal. Now, CT of the PNS performed in the prone position with the head hanging down, and the disadvantage is to identify the site of active site only. Could not detect the inactive intermittent leak, and it is an invasive procedure and increased radiation alone, a risk of associated lumbar puncture, and intracranial administration of the indurated course. And the indication for this above CT cystoscopy is like evaluation of the CSF leak in the patient with multiple fractures of the immune defect, and in the patient with suspicious bony defect with clinically confirmed CSF leaks. So this you have to write, and this you have to remember in bit hard. And in contrast enhanced MBC, MRC, the procedure intrathecal administration of the 0.3 ml of gallium based contrast agent and algorithm acquisition of 2-dimensional, 3-dimensional section T1 weighted image is performed. So here the sets of images taken about 1 to 2 hours after contrast administration and about 24 hours delay when necessary. Findings are hyperintense fistulaceous tract with osseous defect. So if you will see the patient on CT cystoscopy or in the contrast enhanced MBC, you will see the position, and the advantage is identifies the meningoceles, and it has lighter sensitivity than the CT cystoscopy. And it has higher sensitivity than CT cystoscopy for detection of CSF leak, especially in the intermediate lag. No difficulty in the definition of the lead adjacent in the density bone. So the limitation is lack of the United States of Food and Drug Administration. Its approval actually is intrathecal administration of golodium contrast, and recent evidence of planetarium definition of following administration and intrathecal. However, the dose in the MR chromatography, MR cystoscopy, is much less dose causative effect. So contents of the MR cystoscopy is removed from the problem solving tools. Now, radionuclidic cystoscopy is also there. This is also one of the very good procedure in the case of the head and neck imaging. And procedure is intralethical installation of the radio tracer agents, especially technetium 9 neodymium, followed by acquisition of images, and finding out the identification of the radionuclear activity of the paranasal sinus or the nasopharynx, and detection of the CSF leak improved by the measuring radiotracer activity and Plages activity are nasal cavity are 24 to 48 hours, and combined as a positive CSF leak when the patient to renin activity mode is 1.5 to 3.1. Now, advantages of the radionuclide cysteinography is useful in the intermediate CSF leak, and it can provide an alternative to mobile, especially it causes intermediate CSF leak to confirm the presence of or absence of a CSF leak. So this is the main function of the radiologic anatomy and central phase lesion and the CSF rhinorrhea. Images, what are the images of CSF rhinorrhea? You already understand what we do when we want the images of CSF rhinorrhea. So now today I am closing this part. In the next part I will be starting about about neurology and head and neck imaging only. I will be moving forward, and if you have any doubt you can ask in my WhatsApp or in my messenger. Thanks a lot.